Welcome, bienvenue. Wherever you are joining us from, across Canada and around the world, you are so welcome. My name is Dr. Jillianne Code, and I'm joining you today from the campus of the University of British Columbia, located on the unceded ancestral territory of the Musqueam. And the city of Vancouver is located on the traditional ancestral unceded territory of the Squamish and the Tsleil-Waututh First People. So wherever you are, let's think about and remember and acknowledge the native lands on which you are currently living and working. When I was first diagnosed with heart failure at the age of 27, I never could have imagined a gathering such as this. And now, after 16 years and 2 heart transplants, I cannot imagine my life any other way. With the gift of this community and the gift of life that only heart failure could give, I know that we are here to engage, educate, and empower each other and each and every one of you to understand it's about life, not failure. As president and co-founder of the Heart Life Foundation, I have the honor of calling upon our keynote speakers this morning to start our day. Mr. Marc Bains is the vice president and co-founder of the Heart Life Foundation and a transplant recipient himself, and my friend. Following Marc will be a welcome from our co-host, Dr. Anique Ducharme, president of the Canadian Heart Failure Society. So thank you again for joining us today. Merci beaucoup. And now over to Marc Bains.
Thank you so much, Jillian. I appreciate that introduction. I will be sharing my screen, so please bear with me for just 1 second, everyone. Welcome today. We really appreciate everyone being here. I mean, this is just a unbelievable turnout and just an opportunity for all of us across the country to engage with each other, to network, to learn, and really to empower to improve outcomes. Beautiful. If you can't, please let me know. So today we are here to engage, educate, and empower. As part of this opening session, I'm going to talk to you about our patient journey, as well as the patient heart failure charter that we developed over the last, I would say, 1.5 years. We'll also move into a little bit of a discussion around the need for a national standard of care in Canada. I know Jillian alluded to this already, but I'd like to do the land acknowledgement again. I'd like to acknowledge that I live, work, and play on the traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people. So please just take a moment to reflect where you are in the country or where you are in the world. No disclosures. I always like that slide. It's quick and easy. As mentioned, I'm going to talk about the patient journey, the patient charter, and the national standard of care. So what is the patient journey, and why is this something that we created? Upon our conversations with our members from across the country, we got to understand what their journey up into heart failure to that diagnosis stage looked like, that point at diagnosis, and then living with heart failure. And what we found, there was a lot of different ways that individuals got to heart failure. That diagnosis, that transition to care was almost a lot of similarities. And then living with heart failure had different challenges and opportunities. So this patient journey was developed for a few reasons. 1, to understand the gaps in care, but 2, to understand what those opportunities are for care, and to provide hope that individuals can live the life they want to live, that they can live the quality of life they deserve through heart failure. And so what do? We did a few things. First, we interviewed patients and caregivers from across the country to get a wide scope of what this looked like. We also took research from workshops that we held over the last 2 years with probably about 100 people to talk about gaps in care, what that journey looked like, what that unique experience was. And then we interviewed healthcare professionals as well to see what their perspective was, get a different lens on the journey of heart failure. And so this first picture, and we wanted to do it graphically, not the typical science background of that journey, of what a patient journey looks like. And so these are real life stories. And some of this will resonate with the patients and caregivers, as well as the healthcare professionals. What did you experience leading up to diagnosis? It's hard to breathe, hard to walk up the stairs. I was swollen in areas that I wasn't swollen before. Started to get chest pains. If you look at all these different images, male in their 20s, newborn male, female professional in her 40s, mother of 2 children, heart failure can affect anyone at any time, but it's also an invisible disease. So it's important to know what these signs and symptoms are. It's important to learn and be proactive and get the care you need when you need it. After leading up to diagnosis, we looked at what does that initial diagnosis look like? For me, it was scary. I was 23 years old. I'm sure a lot of people have heard my story. It was the first time that the words heart and failure were used in the same sentence. My first question was, am I going to die? Because I had no idea what heart failure was. I had these initial feelings of being overwhelmed, information overload, this anxiety. And then there's secondary feelings that people experience. All the stuff I was going through the last few months, okay, there was a reason for it. And now there's an opportunity for me to get the care that I need. We look at education. What information am I going to get to make sure that I can take charge of my heart failure? You have information on medications. You have information on activity, getting back to work. All these questions that people had upon diagnosis. And then at discharge, what does that discharge experience look like? And that's an integral point in the heart failure journey, because that can be the difference between a good quality of life and one that's not so good. So it's important to understand the experiences that people went through in these different stages. And then we looked at through the journey living with heart failure. So immediately after discharge and then long term. And I encourage people, I mean, this is just a small portion of this journey for this presentation. But if you go to the HeartLife website, you can download the full journey and you can understand some of these experiences and challenges that people went through. But everything we do with the lens of how do we improve? How do we change the way things are being done? And so when we look through the journey and these gaps in cares, we wanted to understand where the opportunities were. And so there's opportunities with how might we statements. And so this is something that I would like all the participants who are here today listening to these presentations to think about going forward. When you hear information from people with lived experience, from healthcare professionals, think about how can we improve on these challenges? How can we work with some of these great ideas that they're doing and implement them in our local areas or support the communities that we have? So from our patient journey, we realized, how do we create awareness for heart failure? We want to look at mental health support through the journey. How do we improve mental health support? Because heart failure is both a physical and mental burden. And you're going to hear that in our Stronger Together session later this afternoon. How do we help people live the way they want to live after diagnosis? How do we create a more empathetic, informed, and empowered discharge experience? One of the major topics you want to talk about is advanced care planning. And that's something later in our session as well, but something that's often overlooked, but it's important to talk about and empathize with. How do you improve access to care? Canada's a large country. I live in urban Vancouver. I have access to three hospitals with heart failure centers, but I'm often the exception and not the rule. So how do we make me the rule and not the exception? How do we build communities around heart health? What we're doing right now, we're bringing people in from across the country, healthcare professionals, patients, caregivers, people in industry, the public, to drive conversation. And how do we transform healthcare culture together? All of this patient journey, and these how might we statements led to the development of the Patient Charter of Rights. And so what is a Patient Charter of Rights? This is something that sets the rights and responsibilities and really supports the creation and implementation for a national standard of care. As I alluded to in the last slide, I have access to some of the best care in the country, but I am often the exception and not the rule. So how do we then create this access to care for everyone across the country? So this patient and caregiver charter is for people to understand, combined with the journey, what to expect through their care continuum, to give them the education to empower them to ask the right questions, and also to understand their responsibilities as a patient and caregiver. For healthcare providers, it's to understand what that lived experience looks like, to take the patient chart in a lens in terms of the decisions they're going to make, and work with patients or caregivers to make those decisions jointly, and for policymakers and private payers to identify opportunities to improve care. Why does Canada even need a patient charter? Well, there's over 600,000 Canadians living with heart failure. That number is probably much larger. We have over 90,000 new diagnoses of heart failure every year. It's also an economic burden. Heart failure costs the healthcare system almost $2.8 billion per year. And I don't like to use the word burden, and you see it here for emphasis, but it's a challenge for people living with the disease. When I was diagnosed with heart failure at 23, my life stopped, but everything else continued. There were still things I wanted to do. I was starting my career. I wanted to travel, lots of opportunities, but I was stopped by heart failure. Fortunately, I was able to get better. I had ups and downs, of course, like all of you do. I had my heart transplant in 2018, and here I am today with the opportunity to speak to you. But it's because the care I got, and everyone deserves that same care. As mentioned, the aim of the Charter is to improve the overall quality of life for people like you, for people like me, for folks that may not have heart failure, for people to create that awareness when they do have heart failure to get the care that they deserve. Some of the patient rights, and this will look similar to our journey, and that's on purpose. But the first one is receipt of an accurate and timely diagnosis of heart failure. It's important once those symptoms start to get the care that you need. Availability of services and resources to support mental health throughout my care continuum. And we'll touch a lot on that during the entire conference. Access to educational tools and resources, events such as this. HeartLife has an academy that we're going to be launching late summer to provide patient-driven education to engage and educate people so they're empowered. Create empathy and compassion for healthcare providers. Access to multidisciplinary care teams. When you look at the agenda for today, we have healthcare professionals from across the spectrum. And that just is the holistic approach that heart failure needs, because it is different facets and it does take a team with the patient and caregiver at the center to make this successful. Timely access to the best standards of care. What does that mean? That's innovative therapies, medications, cardiac rehab, mental health support. It's great that it's there, but we need timely access. And then opportunity to provide input into decisions regarding the future of healthcare. And I would say we're moving along the spectrum for timely access. And silver linings with COVID, of course, it showed that the healthcare system is able to adapt in a rapid pace. We've now implemented virtual care and telehealth. And so we're able to provide this rapid care to people that might not necessarily have had it before. And so this all leads to our national standard of care and need to create that equal access across the spectrum. The next presenter, Anique Ducharme, is a healthcare professional. She is the president of the Canadian Heart Failure Society. And I'm just honored to be presenting alongside of her. And it's just a testament to the work that we're doing in this country to bring together healthcare professionals, patients, caregivers, people with lived experience, as well as public policy and industry to improve the healthcare happening in Canada. I want to thank our sponsors, because without them, none of this would be possible. Anique, I'll stop sharing my screen and I'm going to pass it on to you. Hello, Anique. I don't think we have your audio.
Mark, do you hear me now? Do you hear me now?
Yes, we can hear you and see you, Anique.
Okay, so can I shush? I'm sorry about that. Can I go back?
Yep, please start.
All right.
Yes.
Sorry for. So I was automatically muted, but I thought it would be automatically unmuted. But that's my bad, my technology problem. So let's start the discussion. Those are my disclosure. The Heart Failure Society is to improve the care of patients through research, advocacy, education, and development of best practices in the field of heart failure disorder. As of November 3rd last year, there was a lot of turmoil south of the borders, but I became president of CHFS. It was an undisputed presidency, thank God. But my two objectives are basically to bring attention to heart failure, what we call awareness, but also try to help reduce its impact on Canadian living with the disease through healthcare provider adherence. I know those are two very big goals and not going to be accomplished all that in the 2 years mandate that I have, but at least try to set the road that put the train on the tracks. And I strongly believe that together we can make a difference. You know all those statistics. I agree with Mark that 500,000 people living with heart failure is probably an underestimate because a lot of people don't know they have heart failure. And there's an extra 50,000 patient every year that comes in. 2.8 million was 3 years ago, so probably the numbers for only the healthcare system are extremely important, but it's even more important the cost that you incurred when Mark had to stop working for a while and all that. And this is not contabilized in all the Heart and Stroke Foundation numbers. I would just go on the lower bottom with there is no cure. It is true that there is no cure, but we have excellent therapies, pharmacological and device one. And but we have to work together to bring that to every patient with heart failure. So this is a schematic on the left for men, on the right for women, for mortality rate for heart failure. And just to bring your attention that in red, it's heart failure. And you can see that 6 to 8 years after diagnosis, only lung cancer kills more Canadian than heart failure. So why is it that we do not seem to have the same urgency to diagnose a patient with heart failure as we do for cancer? Let me tell you a bit about myself. I don't have a journey as challenging as Mark's had, but lately I change ages and I receive a letter from my health ministry to pass a mammogram. And they say you go, there's a list of clinic and all that, and you really have to have that mammogram. My GP already took care of that, but that didn't know. So I was a bit both surprised and shocked because if you go on the heart failure, on all the online questionnaire to assess your risk, well, my risk of breast cancer is 1 in 9. But if you do the same maths for heart failure, my risk is 1 in 3. I didn't receive a letter to say, talk to your family physician about heart failure, go and get a BNP or whatever. And why is it that there's so much discrimination between diseases? Well, I think we owe to our oncology colleagues, they've been the champion in disease awareness. And we've been on the poor side of things, I would say. Oftentimes, our patients are elderly, and even some family practice and even some cardiologists don't know all the numbers So we've always been behind. And as you know, advocacy in heart failure is in its infancy. This Mark a few years back. Sorry, Mark. But I think now it's time that we roll up our sleeves and we learn from the best who've been doing that for 30 years, mostly oncology and HIV. And not to steal their idea, but learn from them and move forward so that we can really make a difference for both patient with lived experience, but also those who don't even know they have heart failure. Let me switch gear a bit to go towards my second goal, at least try to start up improve care in Canada. I think many of you have already seen this schematic. It's on the y-axis is the function of the heart and according to time. So patient has peak and valley in terms of health state. Can have a plateau for sometimes few days, few weeks, sometimes years. And you can have some ups and downs, both in terms of physical health, being hospitalized and all that. We know there are two very important phases in terms of readmission. This is a patient who has been admitted have one chance out of 5 to be readmitted within 30 days. As some series says even 1 out of 3. So the red zone, I would say the danger zone, are the one once you're discharged from hospital. And then you can have a long plateau like we saw in the previous slide. And at the end of the road, there's either palliation, advanced therapy, and those are very important things. CCS benchmark, Canadian Cardiovascular Society, recommends follow-up within 3 weeks of hospitalization, but there's no indicator to see if this is done or not. Furthermore, on the right of this slide, people have to realize, and when I say people, it's not only patients, a lot of physicians, nurses, healthcare providers are not aware of that, but the hospital admission is a ticker that things are not going well. And the more you have hospitalization, the worse is your prognostic. And it's for us, both patient and doctors and the whole team, to realize that and try to change that clot. Because one hospitalization decreases your median survival by almost half for patient with heart failure. So those numbers are important because we have to intervene when it happens and not wait at the 4th admission. So, okay, maybe this patient needs a left ventricular support, surgery, transplant. There are many possibilities, but we should not wait until the 4th hospital admission. And to do so, we have guidelines. Those have been published exactly a month ago. And every year, we have new guidelines. This year, I'm part of the guideline committee, and this one we really focused on heart failure with reduced ejection fraction, and came out with this schematic where we see we have 4 medications at the top that we should start as soon as the diagnosis of heart failure with reduced ejection fraction is, and should be done by everybody. It's everybody's business, family physician, cardiologist, the whole team. Unfortunately, on these recommendation, the government is not really helpful because some of those agents are not even accepted as first-line therapies. It would be shocking if somebody with cancer, we would say, okay, you have to fail those 3 chemotherapy before getting access to the best one. But this is what is happening actually for some of the agents we have. And it's extremely important. This is based on a randomized controlled trial. And if you look at the class of medication we have, the ARNI, the Entresto, beta blocker, ARM, aldactone, or eplerenone, or SGLT2 inhibitor, which was a diabetic agent that's been proven to be a cardiac agent, a little like Viagra was angina medication. It's not very good for angina, but people really want to keep their Viagra. So we have 4 agents, and if we treat our patient properly with those with heart failure and reduced ejection fraction, 2-year mortality will drop by 75%, from 35% to 9.5. This is a number to treat of 4, like the fabulous 4. But we have to bring this treatment to every Canadian with heart failure and reduced ejection fraction in the country to make sure that they have proper quality and longevity of life. What is really happening? Those are data from the US. And if you look at the class of medication on the upper left, the ACE inhibitors, on the second, ARNI, the sacubitril valsartan, and Entresto beta blocker, and the MRA, those are like the classes that are recommended. SGLT2 was not recommended at that time. And we see in red, which are the medication that are either below the dose we're aiming or not receiving the medication, just like giving half the dose of chemotherapy for a cancer patient. You could see that the vast majority of the patients were not treated properly. And if you look at the stable and target in green, you could say that it was somewhere between 0 and 22%. So grossly, those patients aren't undertreated. Furthermore, if you look at the 3 class of recommended agent at that time, less than 1 patient were receiving triple therapy at the recommended target dose. And it doesn't change once they're followed, because this was a snapshot, but they follow the patient for 12 months. And look at the gray for any of the medication. And on x-axis, those are the month after a follow-up. And you can see there's no change. Basically, medication are started or not started at very low dose, and there's no major change in improvement of treatment over time. This is in the US, almost 10,000 patients, so a wide area of clinicians taking care of those patients, but not much effort to increase the chemotherapy to what is actually recommended. Okay, how are we doing north of the border? This is a study from my hospital that we looked at our database, a little above 500 patients, already all have reduced ejection fraction and been followed for 6 months. We do realize that some of the patients we want to give you, some of the medication we cannot. There's limitation in blood pressure, heart rate, symptoms, and some blood tests that would make it dangerous to put to target doses. So obviously we don't do it. If we look at in blue and sort of yellow, which is the physiological target, we were doing pretty well, except for ivabradine, that in our population was less than 5% once we pushed the beta blockers. And what is, I would say, the most concerning thing is we still had 25% range of patients who were under titration. That means we did not change the dose, and that have been followed for at least 6 months. So we have to continue in there, even though this is good news, we have to continue in that direction, because 1/4 of the patient, the medication were not pushed forwards despite absence of limitation or symptoms limitation. And why is that so important? Because the medication we have work, and they work quickly. On the left is from Paradigm, and on the right from Shift. So with Entresto and the ivabradine. And just look at the x-axis on the left part. Those are days after you start the medication. So within 30 days of starting this agent, there's a 40% reduction in heart failure hospitalization. I told you previously that the hospital admission is also a marker of progression of disease. So we have to do better. I know, Marc, I've been telling you for a while now that I'm dreaming of an ice bucket challenge for heart failure patients. Some of my kids dropping ice on their head and just sending that to friends. I think we need to increase disease awareness. Patient, not only for those with living experience, but for patients who are short of breath and thought they're just aging or they're out of shape. Okay, it's not a good timing. This is COVID now. And if you're short of breath, you might think about COVID. But disease awareness is extremely important and work to do. And we can also work on treatment optimization. I think I know it's like climbing the Everest, but a lot of people do climb the Everest. They train, they get ready, and they go one step at a time. So I think we can climb our Everest if we go together as a team, one step at a time. And I steal that slides from Lynn Warner Stevenson, and I think it's very important that everybody is involved and not just it's not my job and somebody else will do it, because everybody is concerned by heart failure. Thank you very much for the opportunity. I really appreciate it. And I'm going to stop sharing.
Thank you very much, Dr. Ducharme and Marc, for the amazing presentations. And it's just actually sparked some really great discussion so far in the chat. So we do have a couple of questions, and for those of you, and we do have some time, about 15 minutes or so. And so if you have some questions, please post them in the chat, and we will either invite you to turn your camera on and your mic and speak them out loud directly to our speakers, or I'm happy to just ask them for you in the chat. So first up, I think we have a question from Sunny Tut. Sunny, did you want to come to the stage and ask your question?
Let's see. We might have to bring him in. Oh, there he is.
Yeah.
Can you guys hear me?
Yep. We can. Hi, Sunny.
Great. Hi, how are you? So my question is, why is heart failure not diagnosed as other diseases?
That's a great question. And it's a question that I think that we ask along the way, and another reason why we wanted to do that journey as well, to understand that question. And a lot of it, I think, is because it's an invisible disease. Anique put up a slide, and she had my baby pictures. I still had the same curls, but if you look at me, you look at yourself, Sunny, you look at Jillian, and a lot of the people that are participating in our groups, we don't look like we have heart failure, right? And I think that's one of the major reasons, is that it is an invisible condition. And if without understanding the signs and symptoms, one's not likely to diagnose it. And so I think, from my opinion, that's why. I was 23 years old. And, the first 2 times I went to my GP, heart failure wasn't even on the table. It's because why would, someone like me have heart failure? And so I think that's why. Anique, what are your thoughts?
Did your GP prescribe you Ventolin?
So what my GP did, he said, yes, is your childhood asthma and potentially a cold and a flu. So I had my...
That's very interesting, because we have, well, obviously it's not data on 10,000 patients, but the data we have is the first medication prescribed for heart failure patient is Ventolin, and it usually precedes Lasix by 6 months. So we need to raise awareness. I know it's a journey, because we need to raise it. If you have a heart attack, it's probably easier, because you went in hospital and then you say, okay, patient has proven that already this person has heart disease, and then it's probably easier. But I would add to Marc that it's also insidious. It builds up gradually. It's not like one morning you're like out of breath while you were partying in top shape the day before. So it needs a really high index of suspicion to think about it. And I think that's one of the reasons we need to increase awareness throughout the population, and not only with the healthcare provider, but we should do it with HCP as well.
Mm-hmm. It's a great question. Thank you, Sunny.
Thank you.
We actually, and that does bring about the question of screening, in thinking about, well, what can we do to help or to even screen for this condition? And Cynthia actually has a really great question. And actually there's a Q&A function, which I should have known, but so you can actually use that if you like, rather than the chat, but either works. So Cynthia, would you like to come on camera, or do you want me to just read the question?
I guess we won't know.
We won't know. How do we know? Okay. Camera is fine, she said. All right. Well, turn on your camera and come. I think you have to come to the stage. Oh, I don't know if you can. Oh,
Yeah,
perfect.
yeah.
Well done. There you are. Hello.
It is actually quite easy. You just hit the camera on and mic on. I didn't think I had the ability to do that when I wasn't a presenter. So this place is really cool. I love this program. So I first and foremost, I wanted to just the aha moments. I got diagnosed with my idiopathic dilated cardiomyopathy about coming up 7 years ago. And so I've been doing tons and tons of heart awareness and advocacy work since then. And the thing that struck me in the conversation, or in the slides that you presented this morning, Doctor, was that, breast cancer is 1 in 9, heart failure is 1 in 3. So I got that same little, I got it sitting on my table over here. Let's go get a mammogram because you're in your 50s now. Like, it's astounding. I know, it's lovely, right? It's like, hey, you're an old lady, go get your boobs checked, right? Like, but whatever. Sorry for the crassness, but it's like, why is that the focus when we see 1 in 3, right? Like I'm this, like Marc says, I don't look like I have heart disease. I teach a fitness class. I'm at the gym all the time. I'm young. I used to be young, but why are we not doing echoes at least? And why does it have to be 40 or 50? Why isn't it in our 40s? I don't understand.
It's a great question.
I think we have a lot of work to do. I remember when I was a med student, the HAI brought forward the patient advocacy. They were bringing new medication that we didn't know exist, and they would bring it to us and say, okay, can I try this medication? Can I be on this clinical trial? And we're fortunate enough that Jillian and Marc put forward this Heart Life Foundation so that people can be together, and we're stronger together. We need to do more. I think we're getting in the right direction. The Heart and Stroke Foundation has a heart failure roundtable in June. Just spoke earlier on this morning with our president of the Canadian Cardiovascular Society, that he makes it also his priority. So together we could probably do more in terms of awareness. Ice Bucket Challenge Part 2, or whoever wants, but I think we need to start. We're really starting the game late, probably because patients were too sick. Oftentimes, because HIV patients, when they got the disease, a lot of them were in top shape and very vocal about it. Whereas, remember when you got actually diagnosed, I'm not sure you were really healthy enough to go in Ottawa and say, we need advocacy, we need this and this. But it's obvious that when physicians are like going to the health ministry, it's just physician that wants a new drugs or whatever. When patient goes there, it multiplied by 1,000 our voices. So I think just today is a good example that we're moving forward in the good direction, and probably put the foot on the speed pedal to go much faster than we've been in the last years.
And I'll follow up with that to say that you're exactly right. When we started the Heart Life Foundation in 2016, we almost snuck into the Heart Failure Update and had an opportunity to speak Dr. Jonathan Howlett was gracious enough to give us 2 minutes at the end, and we were just starting. The year after, we were able to participate in a few workshops. After that, we were in a plenary. And today we have a full day event in partnership with the Canadian Heart Failure Society, with physicians, healthcare professionals across the spectrum, and people with lived experience working together to change that conversation. And knowing what we know about some of the work that's happening globally, I would say Canada is pioneering this approach. And so, we should all be proud of that. There is, of course, a lot of work to do, but we're on the right path. Ice bucket challenge might be a little bit too cold, so maybe something a little bit warmer, like a lukewarm bucket challenge, but I'm interested in moving forward to create that awareness drive.
Yes, I'm not sure heart failure patients need the additional shock to the system that ice would provide. However, it is noted, and so we welcome any ideas from people in the audience, as we have a wide variety of people participating, the vast majority of whom are patients. And so it's really well noted, Anique, that we do need to come together because we need to amplify the patient voice, but by doing so, as you said, only adds a bullhorn to the physician side as well. So we really need to do this together. There was also some discussion, actually quite a bit of chat going back and forth about the BNP. And I'm wondering, I know what it is, and I know Marc knows what it is, but I think it's worth a little bit of discussion around that and why it might be something hopefully simple that we could really advocate for as a first-line screening tool. Anique?
Well, being that is secreted by the heart, so there are other circumstances where it can arise, but majority comes from the heart. So if your BNP, the normal is around 25, but a patient with heart failure and cardiogenic shock can go up to 35,000. So as a screening, it has been tested, and you can obviously do wide screening, but you have to screen a lot of people. But it's about the same as for the mammogram. Those were my own risk. For somebody above age 40, it's 1 in 5. It seems like I have bad genes, but that's another story. But BNP could be our mammogram. Unfortunately, it's not available everywhere.
Yeah.
Because it's an $18 test, but mammogram is much more expensive than that. So it could be a start. And then access to echo, there's a lot of access problem in heart failure. But like the cancer patient made it work, there's no reason we could not.
Mm-hmm. Great. What do you think, Marc?
Yeah, no, I agree. And it comes back to that equal access to care and creating that national standard of care. As much as, I think we have a wonderful healthcare system that, has saved our lives multiple times, but there's still that inequality of access across the spectrum, whether that is through proactive testing to be diagnosed with heart failure, or access to care after you're diagnosed with heart failure. And so there needs to be work done to ensure that if I can get a BNP test in BC right away, that I should be able to get it in Manitoba, PEI, the Northwest Territories. And so that could be one of these challenges that we take on, because it is such an important tool to help diagnose heart failure or look at worsening heart failure. And so opportunity exists there for us to do that, and maybe make that a main stage for this national standard of care.
Mm-hmm. There's actually two. now we've started a cascade of questions around BNP, but there's two questions I think that are somewhat related. I guess in terms of a BNP level, Anika, like at what point, if somebody's level is like at 3,000, 4,000, 5,000, and BNP is a simple blood test. that can be done, like you said. So if somebody's BNP is in the thousands, wouldn't that spark further investigation?
Well, I think the most important thing is if people are totally asymptomatic, no shortness of breath at all, I'm not sure it's worthwhile sending it everywhere because the likelihood of having a disease is very, very low. And but it should be a trigger for further testing. But usually, if you have somebody who's like short of breath, do the test, and then it should be all protocolized like it is in cancer. And I know I'm talking to patients, and some of my colleagues say, "You're not going to talk to heart failure patient about like cancer." I say, "Yes, they take the chemotherapy every day," and I think we got to call the risk, but also the benefit of those medications, reducing a risk by 75%. It's not a lot of medication to do that. We have device. I didn't talk even about devices that we have both for monitoring and treating heart failure. But for at least our BNP for those who are mildly symptomatic should be like, there was a big campaign in the US. Do you know your EF? That was from one of the devices company because they want to sell more ICDs. But do you know your BNP could be one?
True, very, very true. Well, we have 1 minute left, and we already have an amazing idea, Anique, for your ice bucket, but it's not ice bucket challenge, from our dear friend Moira Teed from the Canadian Medical Association and a patient advocate extraordinaire. She's calling it Heart Pump Challenge. Pump up the volume on our boom boxes to celebrate life. That's pretty good. Let's get loud, right?
Yeah, let's get loud.
My son is doing that every evening.
There you go. It's a start.
Well, then it's pretty standard then, isn't it? Wonderful, great. Thank you so much, both of you, for your participation today and for really kicking off this incredible day. Anique, merci beaucoup. And so participants, we're going to, just going to bring up my notes here. So when we go back to the floor mode, in order to, we're going to take a 10-minute break, but you can choose between the two different sessions. And what you need to do is you click on the rectangle banners at the bottom corners of the room, the bottom left or bottom right. And they show the session names. So if you can't immediately see them, you can actually just click on the floor and drag it around. So you will be able to then click on the different sessions that you want to attend. But if you have any difficulty accessing the session rooms, please just use the chat function to contact tech support, and our dear friends at Kyle & Company will help us out. So thank you all, and time for a short break. Get up and stretch, and we'll see you in a few minutes in the breakout rooms.
See you guys there. Thank you, Jillian.